Hello everybody, my name is Peter Hudson. I'm the Director of the Centre for Palliative Care and I'm your facilitator for this afternoon's seminar on palliative care for prisoners. In the spirit of reconciliation, the Centre for Palliative Care acknowledges the traditional custodians of country throughout Australia and to all Aboriginal and Torres Strait Islander peoples today. We're very fortunate this afternoon to have two great speakers. We've got Professor Jennifer Phillip and Dr. Stacey Panozzo. Jenny is the Chair of Palliative Medicine at the University of Melbourne and at St Vincent's and the Victorian Comprehensive Cancer Centre. And Stacey is a research fellow who works with Jenny's research group Palliative Nexus. And we're also fortunate to have Stacey as a research fellow working for the Centre for Palliative Care. One of the best things about these seminars is an opportunity for you, the participants, to engage with our presenters through the Q&A opportunity at the end of the presentation. So we're hoping to have 10 to 15 minutes or thereabouts for Q&A. So we'd encourage you to log questions along the way so we've got a pool to draw from at the end. But please don't hold back. You know, it's a great opportunity to liaise with Jenny and Stacey, who are talking about a subject matter that they've researched and have got a lot of interest and expertise in. So we really do encourage those questions. Now, and Jenny and Stacey have got a bit of a tag team, I think, going for the presentation. So I'm going to hand over to both of them. And I think Jenny is the first cab off the rank. So on behalf of all of us, Jenny and Stacey, welcome. Good luck with your presentation, and we look forward to hearing your thoughts and insights. And we'll regroup with you at the end for Q&A. But over to you, Jenny.
Thank you, Peter. Thanks very much, and thanks for inviting us to present this work, which I'm doing so on behalf of our research team, which also includes Dr. Tamsin Bryan, Dr. Carrie Lethbrook, and Dr. David Marco. So at St Vincent's, there's been a long history of a strategic commitment to the health provision for patient groups who are experiencing vulnerability, including those who are in prison, those who are homeless, who use illicit drugs, who have mental health disorders, or who may identify as Aboriginal and Torres Strait Islander. And as part of this strategic commitment, St Vincent's has been very generous in responding to requests to consider this in more detail, and have supported our work in terms of some support for funding for the research that we're presenting today. This really came about from a series of conversations in clinical care where we were struck again by the issues that providing palliative care to people who are in prison and the particular challenges that raised. We were thinking about the issues about the medications that we could and couldn't use, the planning and the follow-up for people who are in prison and how that had to be a bit different, and the whole issue of compassionate consideration and who does that and when does it happen and how should it happen and who's responsible for that. And we were finding that we were needing to have these conversations within our team again and again, and we didn't really have any corporate knowledge or systems of how to do it. And so we thought that it would be important to begin to be a bit more systematic and a bit more rigorous in the way we're thinking about it. And hence we undertook the research program that we will be presenting on. But before I do, just to set the stage a bit, in Australia, there are just under 43,000 people in prison. 1 in 3 have a chronic health condition, heart disease, cancer, respiratory disease. The population in prison is both increasing and ageing. We know that about 15% are older than 50, and 50 is actually defined as being older in prison because of premature ageing. And it's likely this is a combination of pre-existing lifestyle factors and perhaps also the impact of the prison environment. So people who are aged over 50, 15% at the moment, but this is a very rapidly growing population, and these numbers have increased by 84% in the 10 years to 2015. And palliative care, Well, we know with an ageing population that there are more people who are likely to face their end of life in custody, and there are issues around restrictions or to access to care, and there are some delays in terms of diagnosis and difficulties in provision of care. Obviously, people who are in prison have a unique set of circumstances in that there's no choice to be able to die at home. And palliative care within the prison setting is fairly rudimentary. 48% of people, from the Australian Bureau of Statistics, 48% of people died in the prison cell, 11% in a prison-based ward setting, and 38% in a secure guarded public hospital ward, such as the ward that exists at St Vincent's. So this obviously adds significance from the hospital end to the care of prisoners at the end of life. We have at St Vincent's, the care of prisoners in the tertiary setting has been undertaken for many years, and so there have been a number of people who've been cared for, including at the end of life. And there's quite a lot of experience accrued by the health professionals in thinking about this issue, in observing and wondering and thinking thinking more deeply about it. And so we thought it was important to access the views of health professionals as part of our research. I just wanted to show you a bit more on the worldwide stage. This is from Birkbeck University, the Institution of Criminal Policy Research. There's just under 11 million people incarcerated in penal institutions throughout the world. It's actually probably likely to be more than that because we don't have figures from Eritrea, Somalia and North Korea, and they're not complete figures from some other countries. The world prison rate is 145 per 100,000, but this varies quite substantially. The highest is in the US at 655 per 100,000. In parts of Western Europe, it's quite a bit lower at 81 per 100,000. And in Australia, I've just popped the chart from the publication from this group, and you can see that it's increasing. In the year 2000, 114, 2015, 152, and when this report was released, which I'm just trying to remind myself, I think it was 2018, 172 per 100,000. In Victoria, we have about 18% of the prison population in Australia, distributed across a total of 15 prisons in both urban and regional centres, and about 1,100 prisoners who are older than 50. 70% of the deaths that occurred within a particular year when this first slide was made were from natural causes, and that's similar to Australia-wide. And these are the actual figures, again, from the Australian Institute of Criminology. Over 10 years to 2009 to 19, there was 136 deaths in Victoria, 20% of the Australian total. So this is what it looks like. I'm not sure that this is all that visible from where you're sitting at home, but there are 15 prisons across the state for adults, and we have 5 maximum security facilities, which are in orange, and they're mostly around the metropolitan region. 5 medium security prisons in green, which are a bit more distributed, and 5 minimum security in purple, and you can see them also largely around the regional part of Victoria. Langley Calcul is an example of a minimum security prison, just over 400 prisoners. It's a working farm with a few thousand acres, and prisoners have the opportunity to do a series of activities, including woodwork, metalwork, shearing, for example, gardening, poultry farming. The prisoners live in share house accommodation, type house accommodation, with a building and not their individual cell being locked down overnight. The buildings are open from 7 until 9, so they have around 14 hours outside their buildings. By contrast, Port Phillip, which is a maximum security and Victoria's largest prison with over 1,100 prisoners. You can see from the perimeter around, there's a significant perimeter around, and there are 13 accommodation areas or secure zones within the prison walls. The cells are open 7 AM and locked down in the evening, and the prisoners, depending on their level of security, can have up to 8 hours outside their cell. The Port Phillip acts as a transit hub, so if a prisoner is in a medium or minimum security, or indeed another maximum security prison, but requires ongoing health treatment or access to secondary or tertiary level care, they're mobilised to Port Phillip maximum security prison, irrespective of their sentence. And Port Phillip includes a 20-bed ward, which is St John's ward, and also a 30-bed psychosocial unit. But from Port Phillip, then the patients, or the prisoner patients, are able to be transferred to St Vincent's, which is the Blue Star, for their tertiary or secondary level care. So I just wanted to perhaps give you an example of a case, and this case is a constructed case with the details of a number of different people put together and done in this way to obviously for preservation of anonymity. Let's say a 51-year-old man in medium security prison in regional Victoria who has cancer, metastatic colorectal cancer, and requires chemotherapy. So he needs to move from his low-level security prison to Port Phillip maximum security prison, gets allocated a cell, and then is transported from Port Phillip to St Vincent's Hospital for each of his outpatient chemotherapy appointments. When he sees his oncologist or palliative care physician, it's in a special outpatient room and there's security guards in attendance. The clinicians can't book his future appointments in the same way they would with other patients, as the prisoner or the security guards are not able to be made aware of future movements of the prisoner. On occasion, the patient, our man, might miss his appointment due to transport not being available, or perhaps the transport is being required to take people to court for court appearances. Perhaps there's not enough guards to help facilitate the transit of patients. When in Port Phillip prison, his medications are dispensed from a central location at 2 time points during the day, morning and evening, and doesn't have access to, for example, breakthrough pain medications outside this time. He has to physically walk to get his medication and swallow it in front of the staff. He can't have patches or breakthroughs, as I said, or injectables. When his disease progresses and he needs IV fluids or other care, he might be moved into St John's ward, which is within Port Phillip prison. In this ward, he is in his cell for 23 hours a day, with 1 hour to spend out of it with access to a concrete outdoor area. As his symptoms progress further, he's transferred to St Vincent's secure ward called St Augustine's ward, and here he might have a palliative care consult and oncology care over a period of weeks. He can receive breakthrough pain or all the medications and symptom management that he needs. He can be visited by family once a week. There's not phone access for him, but the St Augustine nurses will make and take calls with his family to ensure they're informed of his care. During his stay at St Augustine's Hospital ward, an application for compassionate release is made. However, he dies before this is processed. So today we're giving you an overview of our work. We wanted to show you a little bit of other work that's happening in the field, and then raise some opportunities and thoughts for perhaps going forward. So the aims of our research was to explore hospital and palliative care use of people who are in prison at the end of life, and to understand the healthcare professionals' experience and perspectives in providing this care for people in prison. It was undertaken at St Vincent's Hospital, which is, as you know, 780-bed hospital with 36 palliative care beds and also the 10 secure prison ward beds, which are St Augustine's. We undertook a medical record review of cases and to understand the care that had been taking place in the previous period of time. We also undertook focus groups and interviews, and then did some mapping of services as part of a collaborative European Association of Palliative Care project. So the medical record review, over the 10 years, we examined the inpatient prisoner deaths and extracted data around the final 3 months of their life, looking at the clinical characteristics, particularly focusing on access to palliative care and healthcare use in those 3 months. And of this, over this 10 years, we identified 62 prisoner deaths occurring in the St Augustine's unit. Most were male, with a median age of 57. To provide a sense of usual patient care, we have a comparator patient group who died within the same period of expected progressive, eventually fatal illnesses, but who didn't experience the vulnerability. And you can see that the prisoners were dying about 20 years earlier than the comparator patients with similar diagnoses. We also know that 70% of these prisoners experience multiple vulnerabilities beyond that of being in prison, such as mental health illness, illicit drug use, or homelessness prior to their incarceration. If we look at the final 3 months of life, you can see that the prisoners experience more than double the length of hospital stay compared to the comparator group. This is largely reflective of their stay in St Augustine's ward, but also if they did spend time in the St John's unit, which was the unit, the ward within the Port Phillip maximum prison. Prisoners experienced multiple hospital admissions in their last 3 months of life, and all of them were admitted through emergency department, consistent with the policy within the hospital. A high percentage of the prisoners had an ICU episode in the final 3 months of life. And if we examine the last admission, so this was the admission that it concluded in the patient's death, you can see again that the prisoners had a longer length of stay of this admission, 17 versus 10 days. They had quite high levels of palliative care consults. 2/3 of them saw a palliative care physician, albeit lower use of a palliative care bed. And those who did get moved to a palliative care bed, you can see that their stay was shorter. On being transferred to the palliative care bed, typically they were accompanied by security guards. For some, they were also shackled to their bed. However, they were able to have family and friends come and spend significant time with them towards the end of life. So the summary of this part of the work, I guess we found that prisoners did spend one or more of their final months of life in the acute hospital. They were younger when they died. They had lower use of palliative care beds, and they had high incidence of multiple vulnerabilities in addition to being in prison. I'm now going to hand over to Stacey, who's going to talk about the qualitative components of this work.
Thanks, Jenny. So as Jenny mentioned, we also spoke with health professionals at St Vincent's, as she's mentioned, as she's pointed out, that's where Victoria's prisoners are largely cared for, to understand their experiences, healthcare professionals' experiences of providing this type of palliative and end-of-life care, and seeking to explore some of the challenges and enablers to this care. So we actually spoke with 54 health professionals from various roles and clinical disciplines, and most, as you can see, were female, and 30% of participants had more than 20 years of experience in healthcare. We took an inductive thematic analysis approach with the data, and health professionals described some unique constraints and obstacles faced by people in prison and faced by themselves as they sought to provide optimal end-of-life care for people who were experiencing incarceration. So I'll speak to several of these themes today based on constraints that emerged from these discussions with staff. And this includes regarding constraints on health decisions, place of death, provision and place of care, advocacy, and also care in the last days of life. And as I take you through these, I'll share with you a description of the theme and also an example of the types of quotes that came up as staff shared with us. So irrespective of whether a person is in a minimum or medium security prison, prisoners are required to move from their prison to a large metropolitan maximum security prison setting in order to enable them to, as Jenny pointed out, to transfer to and from a public hospital for a specialist care in this jurisdiction of Victoria. So when we talked to them, health professionals expressed the concern that some people in prison chose to decline or perhaps delay treatment and tertiary healthcare in order to remain in their preferred lower security prison environment. One oncologist highlighted that they lose their job, they lose their room or their cell, they lose their job. So they're effectively discharged from the minimum or medium security prison, even if it's just an outpatient appointment, and that's a big deal. Health professionals expressed their unease that a prisoner's decision to accept, decline or delay treatment is compromised by access to care only being available through a maximum security prison setting. So such constraints on health decisions for a person in prison could at times also result in late or very urgent presentation to hospital with advanced disease. Broader constraints on the provision of care were also raised, including the limited development of rapport with patients when security guards are in attendance with every consultation. One psychiatry doctor indicated that the lack of any sense of building a therapeutic alliance with somebody hovering over you with arms. There's no private space. You couldn't go off in a private room. It absolutely puts a barrier in the therapeutic alliance with the patient. The prisoner security guards run by different rules. Constraints on provision and place of care created a moral distress for health professionals, impacting the normal way of what they're used to in terms of providing care. In terms of constraints on provision of care and a place of death, being incarcerated means those in prison have lost their choice around where they will die. So health professionals describe the challenges they feel in providing specialist care for dying prisoners in the face of this loss of choice. One palliative care consultant reflected on the constraints and shared with us that a major foundational part of palliative care is trying to achieve care in the desired site of care and achieve death in the desired site of death. And I think it grates on us because we're so used to pursuing that, and a person who's incarcerated has lost the privilege of deciding where they are. The experience of the healthcare professionals in providing end-of-life care for people experiencing incarceration really pointed to this sort of deep philosophical or fundamental tension between prison constraints and the foundational principles of palliative care, which are very patient and family-centred. Participants also perceived opportunities for further clarity of the correctional services processes and protocols and aspects of security. They indicated that uncertainty around protocols impacted on their opportunities for advocacy and optimal care for incarcerated person at the end of their life. In describing their experience with a patient, a palliative care staff member reflected that the protocols don't seem to be explicit or consistent. No one knew who to phone to say, can we get the shackles off? And apparently they could have come off. We're now told subsequently down the track that apparently there is a way of doing it. It just doesn't feel as though it's necessarily well known at the time. Similarly, for advocacy, the pathway and responsibility for applications for compassionate release or a downgrade of sentence for a patient experiencing incarceration was often unclear for hospital staff. One oncologist shared that it's clunky because you don't really know who's going to make the approach back to the prison or to the Department of Justice, and where you've got to approach, and like the whole, it's not mapped out. There's not a nice pathway of how to get that happening. Nationally and internationally, there's lengthy processes and variability in application and access to timely compassionate release, and that's very much dependent on quite a number of factors for each individual person in prison. Correctional health staff at the hospital offer support to clinicians and family members of prisoner patients regarding compassionate release. However, it remains an area that needs more clarity around the process of application and the key stakeholders to be involved, and at what time in a patient's illness trajectory can this process actually be undertaken. Too often applications for requests are made far too late, and one hospital correctional health nurse shared that when it got to the point where this patient was terminal and PAL care were involved, the only thing he wanted was to die free. That's the only thing he wanted. And we tried. We told the family this is what you need to do for compassionate release, but unfortunately that was turned down, and the only option was to get him up to the palliative care unit. And that was a battle with corrections, but 2 officers 24 hours a day sitting in the room, but it was able to be arranged. In undertaking advocacy for a person experiencing incarceration, participants noted that they may become aware of information about the prisoner patient's offence and their length of sentence. Health professionals really did vary in terms of their preferences around managing this type of knowledge. One oncology doctor shared that, "I think we've got a barrier ourselves probably for bringing it up in terms of prognosis and long-term planning, because we or I don't want to know why they're in prison because I don't want it to change how I approach them." Some felt that there was a benefit in knowing the prisoner's length of sentence to engage in discussions about the prisoner patient and their diagnosis, prognosis and treatment options, whereas other participants preferred not to know. And when you look at previous international research, it highlights this sort of tension or concern around managing the knowledge about the patient in prison and ensuring that sort of provision of care remains impartial is also shared by health professionals that are in the prison-based setting themselves, so not just unique to a tertiary public hospital staff. The management of pain and other symptoms can be challenging, particularly pain medication. People in their prison cells, as Jenny's pointed out earlier, they don't always have ready access to much needed breakthrough pain medications, and there are set time points at which medications can be accessed, and any needs that arise between those times requiring breakthrough medications are not readily provided without the person in prison being admitted to the St John's ward at Port Phillip prison here in Victoria. So this kind of results in a loss of privileges in a way in moving into that ward. Relating to this, a hospital correctional health nurse described that he would spend the night in pain rather than actually ask for a breakthrough. If you're requiring a breakthrough, this is in prison, a breakthrough morph mix or anything like that, you're in St John's and end of story. Your regular medications are given between around 8 a.m. and 7 p.m. and after that there's really nothing. The prison doors are open only for emergency situations and that's it. Rather than being locked up for up to 22 hours a day in St John's ward where he could actually have his pain managed, he chose to refuse pain relief. And that pretty much is the system. There's not a lot you can do. Health professionals further spoke to the difficulties they anticipate in providing the best pain relief for a person in prison. An oncology staff member relating to this shared that it just seems like it's almost impossible for a patient in a prison cell to be able to access care and meds because it just doesn't happen. That's been very challenging over the years. And many health professionals on this topic, they reflected on a sense of complicity in determining the place of care for a prisoner patient simply by their decision of prescribing certain medications for pain and symptom management, as certain medication types or means of administration in terms of breakthrough drugs are not readily accessible or administered within the prison setting. Therefore, almost determining the place of care for a prisoner to be in St John's at Port Phillip, which is now a 40-bed ward with a new extension completed, or more likely in St Augustine's at St Vincent's Hospital. Participants, specifically those working in the St Augustine's Hospital Secure Ward, highlighted that visits from family are restricted for prisoner patients and that the inpatient secure ward is not particularly an environment suitable for children. The family need to be able to cope, especially if there's kids. One hospital correctional health nurse shared with us, this is not the environment for kids to be in. The family need to be in an environment where they can talk together and grieve together. Staff spoke of some examples of advocacy for patients whereby the frequency of family visits could be increased as the patient did approach the end of life. So those sorts of things in a end of life context can be arranged. So the themes I've touched on this afternoon provide a very rich and collective voice of health professionals from a tertiary hospital setting and their experiences of delivering care for people experiencing incarceration. And our research definitely highlights that there are significant constraints to end-of-life care for hospitalised prisoner patients. and this is certainly perceived by healthcare professionals. And yet, despite these limits, they have a moral imperative to provide best care under these circumstances, and they work and discuss and move forward in these sorts of contexts for our patients. These research findings represent a first step to addressing the lack of research and evidence to inform policy and practice for the care of people in the Australian prison context who are at the end of life. And we're also keenly aware that certainly the voice of people in prison, their families, and also prison-based healthcare staff as well are key to more fully understanding care at the end of life for those who are experiencing incarceration. And this is why we're excited about some of our sort of ongoing research collaborations at present to continue with this work. We have two major partnerships that we're now undertaking that involve partnership with the European Association for Palliative Care and their prisoner collaborative, and it's a group of researchers from across Europe and also Jenny and I representing Australia. And we've been working together more earlier or parts of last year to map the prison and prison healthcare space in Australia, and that's been published with Dr. Mary Turner in the UK and a number of other people from the countries represented. And our next steps are to look at the perspectives and experiences of health professionals working within the prison-based setting itself. And this has led to a collaboration also with Professor Jane Phillips and her research team. They have a nationwide program of work focused on palliative care in prisons that is rolling out over the next 3 years. And this is an incredible program of research across correctional health services in Australia to co-design a palliative model of care for people in prison with end-of-life care needs. So I'll hand over to Jenny now to share some of our reflections, our learnings, and some opportunities as well. Thanks, Jenny.
Thanks, Stacey. So what have we learned along the way? I think some of the things we've talked about already, that people who are in prison are spending one or more of their final months of life in the acute hospital, in hospital care. They're dying younger. They are experiencing multiple vulnerabilities. That there are deaths within the prison setting that we haven't really spoken about. We've really been talking about the hospital end of care. That at that end of care, there's low use of palliative care beds and fairly late recognition of dying. And as Stacey's highlighted, the constraints on care of providing care are quite considerable. I think in sort of thinking about this more broadly, it's interesting to think about some of those philosophical questions, that some of the values that we uphold in palliative care, the aspirations and goals, which actually I would suggest involve notions of freedom to exercise choice, even in the circumstances of illness, freedom to consider whole notions of the personhood, and these intersect with the imperatives of restriction and limits that are required as part of incarceration. I think there's another interesting intersection, that palliative care, explicitly involves family and the community, while in prison it's very much a punishment, I guess, or a restraint on the individual person. Obviously the family is markedly impacted by this, but it's the individual who's at the centre of incarceration. I think that's an interesting sort of intersection of the two cultures as well. Prison has a marked impact on decision making around treatment and care. We spoke of people making choices around symptom relief and restriction of freedom. And I think I would suggest that some of the most frank and open conversations I've had about prognosis and making decisions for or against particular treatments have been with prisoners. This is an area that many of them in this situation are fully engaged with because of all these other implications that it means. And the systems of organisation, the place of incarceration, the different levels of security also influence all of these treatment decisions. Even just how we can review someone, having care in the prison is not the same as being able to deliver care to someone in the community. And that seems an obvious statement, but it's just simply not feasible in the same way. Access to medication, Stacey's spoken about, access to scheduled review, and even the reassurance that that brings is not always possible to be able to put in place in this set of circumstances. And the compassionate review of circumstances, I think we've spoken about at length. I think the other big thing that we've learned is that there's this incredibly highly dedicated group of staff who are involved in protection health services and whose advocacy and care have been, a huge source of comfort for those who have been in prison and facing end of life. But it's also been enriching for us to observe this in action and in care. So what are some opportunities? How do we think about this, and what might be possible going forward? What should we be thinking about? Telehealth has obviously grown exponentially with COVID, and clearly we're much more adept at it now. And its application to the care of people in prison, I think, merits a whole additional piece of thinking and what more might be possible in that space. We've talked a bit about people being in different levels of security prison. We haven't really talked about palliative care going into those spaces, potentially, particularly the minimum security prisons. And as I've said, most of our data and discussion has been at the tertiary and secondary level of care where people are coming into St Vincent's. The whole infrastructure and design of prisons, I think, is an area that is worthy of some discussion and thought, obviously well beyond my pay scale, but I think that it's incredibly important if we are continuing increasing numbers of people in prison and increasing older people in prison, then we need to think about whether the prisons are fit for purpose in the same way. Most prisons are built for young men, and how do you manage if someone's using a frame or needing a wheelchair or needs a special bed? These are things that we haven't really spoken of today, but are big challenges going forward. I'd like to raise the possibility. We know that there are often delays in diagnosis for people who are in prison, and I think that the whole opportunity for thinking about transition points in the illness, and these might be key points where someone should be thinking about this is a good time to think about considering palliative care, so that we're doing this in a structured and a systematic way rather than broadly what we have done in the past, which is sort of when we think about it. I think that it would be interesting also to think about that notion of trigger points around starting processes around discussions of treatment goals and decisions, but also processes about, is this a situation where compassionate consideration should be begun, and that we, certainly on the healthcare side, need to be much clearer about the processes of what needs to be done by whom and when. And finally, I'd like to just raise that there's this great initiative with PEPA education and training. So PEPA being the experience in the palliative approach, with staff from corrections undertaking palliative care placements. I think there is even an opportunity to extend this. We could even potentially, in a creative way, make this bilateral so that palliative care staff understand the environment of care in corrections. And this would build relationships and ensure ongoing bilateral mentorship. And this could really start some of this sort of ongoing possibility for how we might continue to think about and creatively problem solve in this area of care. So I'd like to finish there and thank you for your attention. I'd also like to again acknowledge our co-researchers and also to acknowledge the Inclusive Health Innovation Fund from St Vincent's Health Australia, which has funded this work. Thank you.
Thank you very much, Jenny and Stacey. That was terrific. Greatly appreciate the effort and time you put into preparing that presentation and congratulations on your efforts in somewhat uncharted territory, and very pleased to hear about your collaborations interstate and internationally. But as far as I'm aware, this is a fairly novel kind of research you've embarked upon. So congratulations to you and the team. We've had quite a few questions that have come in, and so a question about the data you presented on, I think it was from 2009 to 19, that slide, and a query as to whether or not you happen to know if anyone who died during that period, if they may have had dementia. You mentioned that they're quite predominantly young, but if you know, that'd be great, and if not, that's okay.
So I'm sorry, I don't have that level of detail from that data. It's from the Australian Institute of Criminology, which is online, but I don't think I don't have it at my hand, and I don't think that it was presented in the report.
Thank you. And just a question about one's just come in for the question is the high rate of death in prisons due to the prisoners refusing transfer or due to the terminal stage being overlooked by prison staff? Do you want me to restate that? Is the high rate of death in the prisons due to the prisoners refusing transfer or due to the terminal stage being overlooked by the prison staff?
Stacey, I'm not sure if you would have a go at that. I don't think that I can comment with any authority about that. There are obviously some, I think the term is unnatural deaths for people, so people who are dying from, not from progressive expected terminal illnesses, so they would account for some of them, and the others I'm not sure.
I'm a little bit the same, Jenny. I think that largely the practice is if the patient has a life-limiting illness and gets to that point of care, that they are transferred from Port Phillip to St Vincent's, where there is palliative care and end-of-life care. This new extension to the Port Phillip St John's ward, going from 20 beds to 40 beds, and also the PEPA training for prison-based nursing staff may shift the number of, but it's still very early days yet in terms of the impact of that training in the bed numbers. But that's the hope.
Thank you both. And a query around knowledge of the actual crime and sentence, and one of our participants has recognised that you noted that palliative care clinicians tend to choose not to know about the sentence, but they're wondering what your view is with regard to whether you think their sentence may impact on their site of end-of-life care.
Stacey, do you want to have a go? Or do you want me to?
Yeah, I'll talk to that. I think I think when decisions are made around certain medication types, that might impact in terms of whether a patient continues to stay on in St Augustine's ward or move to return to the Port Phillip prison. Often when it comes to that end-of-life care stage, as Jenny reflected with the length of stay, a patient with a life-limiting illness at that terminal stage is often spending more than 1 month in the St Augustine's ward. And although we don't have access to the medical records for the patient with any prison-based healthcare that is provided in that context, what we can see is that they have had a stay in the St John's ward. And so there's a clear sense of the duration of stay within each of these wards, and that's obviously because of the level of care that these particular people in prison would require. Not sure if I'm speaking directly to that question though. I'm not sure if Jenny, if you wanted to add anything.
I guess I can only add, not from the research, but from clinical experience, that there is, and it's not quite the same question either, but there are certainly some instances where people choose not to have a therapy because they would prefer to stay in a minimum security environment. And so I guess if they're in the minimum, so I think, I think that this planning is often very explicit. So it does raise an interesting thing, is whether one needs to know a prison sentence or a duration or a crime to be part of the planning. I think, as Stacey said, that seems to be something that the individual health professionals navigate quite differently. So, in a roundabout way, can you have the frank conversation around planning for end-of-life care without knowing, perhaps not fully, but some of those requests for discussions about compassionate consideration may well be impacted by the piece of knowledge that you choose to know or not to know. That was a very convoluted answer, but I think we got there. I'm sorry.
No, not at all. No, well done. Thank you very much. And a question about VAD, the voluntary assisted dying, and we're mindful that your research and attention didn't focus on this, but a couple of questions have come in about it. I'm just wondering if you happen to know whether or not prisoners, if they meet the kind of standard criteria that are set in place, for example, in Victoria, whether or not, in principle, they would be allowed to access VAD. Do either of you happen to know?
So my understanding is that they can, if they satisfy the criteria, and there's obviously a whole series of steps that need to be undertaken, and it probably depends, how those steps are navigated will depend on where they are, whether they're in hospital ward or whether they're in the prison itself, or I guess in a minimum security. So I guess how those conversations would be held and how those processes unfold would depend on where they are. But I think I understand that they, theoretically are able to access VAD.
Thank you. A question that's a comment and question, a recognition that prisoners confronting their end of their lives would be dramatically affected by this experience, and their psychological and social implications of that could be fairly overwhelming, to say the least. So the theory is about whether or not you've got any experience either through the literature or your own research around that kind of levels of psychological distress, whether that was picked up through any of your work, either the research you want to talk, or through your readings of some of the literature, that you were able to comment upon the level of psychological distress for prisoners at the end of their lives.
Stacey, you want to have a go?
Yeah, look, I think just reflecting on a patient record that I've recently reviewed, I think in any palliative care or end-of-life care context, there's existential issues and different questions that come to the fore, and often pastoral care or perhaps if they identify as Aboriginal and Torres Strait Islanders, and an Aboriginal hospital liaison officer could come to see them. So I think psychiatry, obviously, and psycho-oncology and the like. So these, I guess, these sorts of conversations and discussions, referrals can be made to people across the hospital that can actually address those sorts of concerns. And I know, as I mentioned, within the St Augustine's ward, if a patient is very much coming to the end of life, often there's attempts made to, where possible, increase the family and visitation. So all of these things, that the wraparound effect for the patient to alleviate the sorts of concerns and issues that do arise. Obviously, there are patients that would desire to die without being incarcerated, but that's not always something that can be addressed. But every effort is made to address other sorts of issues.
And I guess I would just add that given that this is a population with, as we've said, multiple vulnerabilities, the likelihood of trauma in the past is very high, and I guess that has implications for their psychosocial care. So I think they are at risk of having very high needs.
Thank you. And then a question about whether you may know whether it might be possible for community palliative care teams or members of community palliative care teams to potentially visit a prisoner, in a low security prison to provide care.
I think we know that that's what occurs in interstate in other jurisdictions, for particularly in a smaller state or territory where a tertiary hospital setting such as at St Vincent's in the St Augustine's ward isn't necessarily available. So there are arrangements in different prison settings for community palliative care teams to come in to care for patients at that end of life, but it's not something that I'm particularly aware of for the Victorian jurisdiction. I'd have to look into that and ask our friends at Justice Health to explore that a little bit more. But it's certainly something that, from our findings, is something that we're interested in, because I think certainly lower levels of security, if there is potential for community palliative care to work in that context and with the help of telehealth and other sorts of services, it would mean that particular person in prison doesn't face a further loss of liberty in order to be able to gain that healthcare.
Peter, could I be cheeky and ask if Stacey wouldn't mind commenting on some of the other models of palliative care provision that are available in different parts of the world?
Yes, good question, Jenny. So I think mostly in the context of the UK, for example, that's very much an in-reach model of palliative care for the prison settings in England and Wales, and indeed I think Scotland as well. And so that's where palliative care clinical staff will come into the prison context and provide care in a meaningful way within that prison setting. The US certainly have, as Jenny's pointed out, really different numbers of their prison population, but they are more established in terms of existing hospice or aged care style facilities that are embedded within the prison setting itself, and so they're staffed differently. I can't speak to whether or not they have all palliative care staff trained, but it's all staff palliative care trained. But there's certainly different models, and I think if for the Australian context, it's really great as we move forward with these different collaborations and further research to explore indeed what is the best model for our country, or and is it the same across jurisdictions within our country, or is there variability? So it's something that we're excited to explore more about and learn and implement in the future, hopefully.
Great, thank you. And this will need to be our final question, and it relates to kind of public perceptions and discourse around prisoners and end-of-life care. And the question is, to what extent do you think negative public discourse impacts on service delivery? For example, prisoners potentially be considered undeserving of quality end-of-life care. And do you think more needs to be done to enhance public understanding about the need for quality end-of-life care for prisoners?
I think that's a very interesting and very big question. I think, you know, we're all very familiar with the debates of the law and order debates that tend to take a political slant frequently. And I showed you the figures of the increasing numbers in Australia of percent of people who are in prison. So there's an interesting sort of underlying discourse that I think is not unrelated to this. I don't think that I can comment with authority about whether negative public discourse has an impact, but I guess what I can say is that we have, you know, witnessed and heard about and seen sort of extraordinary advocacy on, you know, the behalf of staff who are actually at the coalface providing care, really sort of going above and beyond, and you know, great nurses haranguing the junior medical staff to get some action for this particular person who really needs some attention now. So I think there are different levels to the discourse, but I think at the actual coalface, certainly in the circumstances that we've witnessed, I think that that's not what's been borne out. I think that it would be great to, you know, have some broader conversation about how we influence the public discourse more broadly. But at an individual person who needs care, I don't think that we could say that we've seen any evidence of any impact of that being brought to the nature of that sort of one-on-one relationship.
Right, well, thank you. And I'm sorry to our participants. There's a number of questions and comments we simply couldn't get to due to time constraints. But thank you very much to everybody who joined today's webinar, and for those people that did provide some questions and comments. And that's been a really helpful and useful discussion. So thank you for doing that. A big thank you to Jenny and Stacey for your terrific presentations, and thank you again on behalf of all of us for exploring this area and for your efforts. So big thanks. And if we're in a live stadium, I think it would be a big sound of clapping hands for you. But just imagine that. And to our Centre for Palliative Care staff, as usual, thank you very much for all the work that you do behind the scenes to make these events happen. And this webinar is being recorded and will be available for our Centre for Palliative website in the course of the next few days. So please, you're welcome to then access it and share it with others. But thank you again, everybody. Enjoy the rest of your day, and thank you for engaging with the Centre for Palliative Care for your continued learning, and we greatly appreciate it. All the best. Thank you.